very much indeed to the Society. Ladies and gentlemen, it's an honor to be invited to address you. This lecture is going to be completely the reverse of the previous lecture, in as much as I'm only going to talk about one patient, and I'm not as clever as Dr. Vasavada. My slides come and go. They don't twirl about and dance, so I'm sorry if you're disappointed. And it's still not advancing. There we go. So this is a single case report with some comments. So this was a man who came to see me because he wasn't happy with his presbyopia correction. He was 48 when he came to see me and a software developer for a bank. So high pressure, lots of money. And he had been a myope who had a LASIK in 2006 when he was 40. And I'm always a bit nervous about doing LASIK in people over 40. And I never do it over 45. And then, of course, he predictably became presbyopic, and somebody else did bilateral light-adjusted lenses with monovision when he was 47. A light-adjusted lens, in case people don't know, is a technology where you put in a monofocal lens, and you can use a laser to change the refraction once it's inside the eye. It's not very widely used, but it's quite clever. Somewhere along the line, he had an ALT for so-called normal tension glaucoma, although I couldn't really see why. But he was desperately unhappy with his anisometropia. He couldn't read comfortably. He couldn't use a VDU comfortably. So there were a number of things at this stage. First of all, the degree of pre-LASIK myopia was unknown. He hadn't got a clue. He was a vague historian. It had been done, I don't know where, but there was no hope of finding out. So that made life a little more difficult. Given that he'd had LASIK, I think a light adjustable lens was quite a clever idea, because we all know that biometry after LASIK is not that predictable, despite what people would like to tell you. And I think that it's also reasonable to offer monovision, but the trouble is this man had never had monovision before, and did not have a contact lens trial to simulate monovision before he had his surgery. So what was he like? Well, first of all, he was unusual in being left eye dominant. So if you're going to do monovision, please check which eye is the dominant eye. The surgeon who'd done it had noticed this, and that eye was 20/20 unaided with a trivial refractive error. The other eye had not bad unaided vision with about 1¼ diopter of myopia, and binocularly he was 20/20 and J3 unaided, which you'd think most people would be happy with, wouldn't you? So he wasn't happy, and I just wondered what my options were. And I think one of the things that we are losing is the idea that if you've got a difficult patient, talk to your friends about it. Just sound out what they would do. And you know what everybody told me? Everybody said, don't do anything. So what did I do? Well, I looked at the options, and the first one was to do nothing, and he was adamant that this was unacceptable. I told him get some spectacles, and he said, no, I'm not doing that. You could do an intraocular exchange for a multifocal lens in both eyes. Now, the problem is, how do you know your biometry is going to be right? I don't. I think that there is always a chance of doing a lens exchange after more than a year that you may damage the capsular apparatus to an extent that fixation becomes a significant problem, and trying to put a multifocal lens not in the bag, you really do get into quite unhappy territory. And then there was the opportunity of a secondary duet conversion. Now, what does that mean? Secondary means that it's a second operation, obviously. A duet means that there's a second lens in the eye. This is not a piggyback lens. Piggyback lenses were designed to go in the capsular bag. Duet procedures are done with lenses that have a platform that is designed to go in the ciliary sulcus. And the conversion is because I was converting him from monofocal vision to multifocal vision. So I spent not quite hours, but a lot of time talking to him, and I got a detailed informed consent that went to several pages. I did YAG laser iridotomies because it helps me sleep at night to know they're not going to get pupil block glaucoma. And then he had immediate, sequential, bilateral, secondary, duet conversion procedures in March 2016. The right eye needed a spherical and toric multifocal correction, and the left eye just had a plano multifocal. And these were 5-minute operations. It's really, really easy, really low risk. These are the lenses. So that's the multifocal, and you can see it goes into the ciliary sulcus. It's very soft, and these little notches help it not to rotate, and that's important with these ones which have a toric marker. So it took a bit of time to settle down, but 3 months later, his unaided vision was 20/25/2020, and his unaided near vision for each eye was J2, and he's a man of few words. He says, eyes are good. So, what are the learning things from here? First of all, don't create surgical monovision without a monovision contact lens trial in a refractive patient, unless they're contact lens wearers and are already used to monovision. And if you ever do monovision, please double check which eye is the dominant eye, because there are left eye dominant patients. And the second thing is why I think I was invited to contribute to this particular session is that supplemental intraocular lenses are a useful tool for refractive problems. And I've got a minute left, and I wonder if I can just take you to the next level. I haven't got a slide, so you're going to have to listen a bit carefully here. What about a patient who's been to see one of my esteemed colleagues in Ahmedabad, for example, and he's listened, and he said, well, I really would like not to have glasses, but I don't know about this glare and halos, and everybody says it's risky to exchange lenses, but, there must be something better. And the answer is, you can do a primary duet prelex. So you put a monofocal lens in the capsular bag, you put a multifocal duet in the sulcus, so they have multifocal vision. And you leave them, well, I like to leave them 6 months to neuroadapt. But if the patient is desperately unhappy, you can deconvert them. It's not an explant, really, because it's part of the planned procedure. You can deconvert them by just taking out the supplementary lens. And that, again, is a 5-minute procedure, extremely low risk. You dilate the pupil, you go in, you pull out the lens. So we now have reversible surgery for presbyopia, and people have the opportunity of trying multifocal vision, even if they think they're not quite sure they want. Of course, they have to have quite deep pockets for all this surgery, but that's that. So, thank you very much, and I hope somebody's going to offer me some of that later on. Thank you for your attention.